Good day, and thank you for joining us for today's webcast. My name is Russell Hendrickson. I'm the CEO. It's great to have you join us today. Today's webcast is using analytics to manage chronic conditions with today's challenges. And joining me is Kelly Constantinidis, who's a senior BI analyst. Kelly, how are things where you are?
Things are well. I'm in upstate New York, and it's a nice day today, thank goodness, because I'm in an old farmhouse with no central air. So these nice days are enjoyable.
I'm in southwestern Connecticut, and it's very warm here, but it's great to have you joining us today for today's topic.
So thanks, everyone, for joining us today. For over 20 years, PDS has been specializing in analytics, visualizations, and data modeling for healthcare organizations specifically. And Russell, you've been with PDS for quite a few of those years, but the last few months, huh?
Yeah, it's certainly been quite interesting. I think 2020 is a year that none of us are going to forget as much as we may want to, right? But it certainly created challenges as a physician or as a medical group or a hospital, right? Challenges all the way around. As you can see on my screen here, these little tiny green COVID virus kind of angry dots there have been causing havoc on us. So the real challenge is, I think, in the beginning, certainly back in March when all this really started and then really heated up in April, our focus was on these types of metrics where we were looking at tests per day and hospitalizations. If we're a facility, we're looking at ICU beds and hospitalization rates. Certainly, there's still a focus across the country because where things started, which was in New York, really right in my backyard, we're doing pretty good in Connecticut and the Northeast. I think Connecticut, Massachusetts are some of the better states. But other parts of the country, unfortunately, are seeing some of the same things. So that, initially it was most offices and clinics shut down or we're doing minimal care. Obviously, that's changed quite a bit now as we found ways to treat patients, but it's still been sort of patients with urgent issues and maybe not necessarily the patients that are most at risk.
Yeah, so as we shift our focus back to patient access and making sure we can get all our patients seen, because we don't want to lose focus on that preventive care. And we want to talk today about some strategies to prioritize those high-risk patients who really need to be seen. If you were able to join us for our last webinar, we kind of talked about the importance of patient contact within the practices and shifts to those telehealth visits starting in March and April, and looking at the volume and distribution of those visits, as we probably saw a lot of volume decrease in that March, April, May timeframe. And, over the next few months, we would expect and hope to see those patient volumes increase significantly. And even though we might see a fair amount of patients continue to use those telehealth visits, it's kind of important that we continue to be able to manage the impact of those visits, and our providers spending more time with those patients, our patient satisfaction rates being impacted over the next couple months, and being able to track that reimbursement related to either telehealth or in-office visits over the next couple months. And Russell, we're talking here about the volume of patients that we're seeing, but we kind of want to talk about those patients that we might be missing or not seeing today.
Yeah, and that's really today's topic. What's interesting is, at least in the Northeast, again, in the areas that were hardest hit, we saw certainly and heard from our clients a real shift towards telehealth in April and May. Although last month, or I guess this month, the beginning of this month, my doctor called up and said, okay, it's time for you to come back in. You've got to be seen. You've got hypertension, and we got to make sure that's being managed. So I saw a real shift back, at least in this area, to more face-to-face contact than potentially telehealth. But what we're going to talk about today is screenings and chronic conditions and the patients that potentially aren't urgent. And as we were preparing for this webinar, it was actually our controller said, hey, did you see that article yesterday? It was just out last week. And when I read the headline, 10,000 more cancer deaths predicted because of COVID, I thought, oh, hopefully not today. But the director of the National Cancer Institute basically saying that their modeling predicts 10,000 deaths over the next 10 years, about an additional 1,000 deaths per year, in part because people aren't getting the screening and the treatments proactively, so that their diseases will progress potentially or untreated or unmanaged. And then when they get to that point where they start being seen, it's going to make things worse. So they've progressed further. So that's kind of an unhappy statistic, Kelly, as you and I were talking about this, is that, well, it's not really fun to talk about more people dying. That's certainly not what our focus is today. So What we really want to do is talk about how can we use HCCs, what are they, and how do we make sure the patients that are at highest risk that have chronic conditions are being treated. So Kelly, do you want to walk us through that?
Sure. So the HCCs CMS actually leverages the risk adjustment model to be able to predict future healthcare costs for patients. So the more chronic conditions or HCCs that a patient has, it gives them a higher risk score. And therefore, the healthcare costs associated with being able to take care of these patients is likely going to be higher. So here's examples of some things that are included in the top HCCs: diabetes, congestive heart failure, things like that. Each one of these has different scores, and we find that providers can actually leverage these HCC scoring concepts to help with managing these patients. So in this particular visualization, this is a web visualization out of our PDS Empower tool, and we've actually been able to identify which patients have HCCs. Now we can start to look at the patient population either by HCC or HCC category, so which type of condition that they have, and look at the volumes by each one of those types. Or we can focus on practice locations or the individual physicians and see who's seeing more and more of these patients. And it helps, allowing our care teams to start focusing on where we need to focus.
Yeah, I think the key is starting with where are the patients and who are they assigned to, right? So that's kind of the first question. So just understanding what their HCCs are. The American Academy of Family Physicians, they talk about HCCs as the ability to paint a picture of the whole patient. And the key to that is understanding patient complexity, cost, and quality. So it's both appropriately measured and then it can be appropriately managed. Just a little fun fact, if you have young children, try to have them say hierarchical condition coding really fast. That is a tongue twister. And I noticed neither you, Kelly, or I have said it so far in this presentation.
Nope.
So try saying that 3 times that fast. It's quite a mouthful. In any case, the HCCs, as we'll call them today for purposes of presenting and try not to trip over the words, they really only work if you have all the diagnoses. So the patient's evaluation and conditions, care, and treatment. And so that would include diagnoses if the patient was seen by specialists, if you're not an integrated health system, right? And we'll talk about the challenges of getting the data to pull all this together. But let's dig just a little deeper beyond HCCs and talk about RAF scores. Kelly, do you want to walk us through what this is and what do we do with it?
Yeah, so that risk adjustment factor score is really, like you said, that whole picture of the patient. So it's actually taking the combination of all of those different HCCs that they have, as well as it will factor in their age and gender. So the more conditions that a patient has, and as they get older, that risk score will go up. That risk score will also oftentimes drive reimbursement. So Medicare Advantage plans, MIP, ACO models, those are all types of payers and contracts that are going to depend on reimbursement. And then in order to get to these RAF scores, we start with the patient diagnoses code. So when patients are seen, most of us all know they end up getting one or more diagnoses codes assigned to them. So there's over 72 of these ICD-10 codes, and about 97 of them map to these HCC codes. So those are the diabetes, congestive heart failure codes, and there's 86 HCCs. Those 86 HCCs actually map up to 19 HCC categories. So I think there's about 10 or so individual HCC codes of that 86 that make up the neurological category within the HCC categories.
Excellent. So, when we talk about structuring data for analytics, people often ask, well, how do you do that at PDS? And this is a simple representation. So we start with diagnosed CPT. We also look at age, sex, the other risk factors that model into this. And those get rolled up into what I call an encounter HCC. So every time a patient is seen, we can look at the diagnoses and then create, was there an HCC generated on that encounter? And from that, we can then roll those encounters into what becomes the patient's year HCC score. We can roll them up into categories. We can start to understand which categories are priority over other categories. We'll talk about that. And then ultimately through their risk score, which is a combination of the RAF score there, we can create what is the patient year's risk score. And we can start to use this to understand how sick are the patients, what are the chronic conditions they have, Are our contracts appropriately adjusted? If they're saying we have patients that are healthier than they are, and we can demonstrate to the insurance companies, and potentially there's more money available, right? So understanding the risk of patients and then ultimately rolling them up into our care teams of physicians, or being able to analyze a particular plan. When we stage this out in our data models, it's very important that we have these tables relationally built so we can structure, slice and dice, drill, and allow the users to work with any of the levels of data they need to really make sure they understand what's going on within the tools. So with that, we're going to take a quick look at another visualization here. Kelly, do you want to walk us through what we're seeing here and how to use this?
This is a report that is intended really to call out gaps in our processes. So one thing that stands out here are these no scores. They're highlighted, easy to see. So these are indicating patients that we've seen in the past for one of these HCCs or underlying conditions, and we haven't seen them in the year specified. So the current year, we may not have seen them yet. It identifies a gap. You can also see the patients had a decrease in a score. So this does not mean that necessarily that a patient wasn't seen and we're not getting the patients in, but maybe there could be a gap in the documentation of that diagnosis code. So at this point with this report, we don't know, but we know that we're expecting to see that HCC coded likely for this current year.
So what makes this so useful, again, is being able to just quickly identify and click on those gaps. So at a very high level, that's really what we're looking for, changes or no scores. And this really ties back to where we have patients with the pandemic that potentially have been afraid to come in. Their appointments were canceled, bumped, or just missed, right? And so now as we start to look back, we can quickly start to identify and create work lists that are what we need to do and who we need to see. The big question is, well, we talked about that hierarchy of how we stage the data. We talked about being able to identify the gaps. Let's spend a minute and talk about where the data comes from. Most people, when they think of HCCs, the common thing they'll hear is they say, well, we're using our EHR. We can calculate our HCCs in the EHR. The challenge with doing that, though, although it does provide a complete view of the patient's history, chronic problems, you'll have your laboratory results, your medications. The downside is this is not the data that the payer is getting. So it may not represent what the payers are seeing and how you're getting paid. All right. It may not also include, if you don't have a complete record or you're not an integrated health system, you may not have if there were hospitalizations. And a lot of the data in the EHR, one of the biggest challenges from an analytics side is it's just not structured and easy to work with. So oftentimes working with just the EHR data doesn't give us a complete picture of the patient's risk acuity score.
So we can bring in some payer data, but Russell, you talked about structure in the EHR. First thing that comes to mind for payer data is the structure of that data and what that'll look like. And it definitely won't be the same across the payers. So that's one problem with that, just relying on payer data. We also can't always validate what the payer has, and it sometimes takes a long time to get that data back from the payer. And then, but one thing or a couple things that we can think about from the payer perspective is that payer data may include conditions that we're not necessarily aware of. So we may be able to get like a better complete picture of that patient.
Yeah, and Kelly, I know from speaking with customers, one of the biggest challenges is there's no incentive for the payer to get it right. And the reason for that is if the payer underreports the HCCs, it just so happens that then the organization, the healthcare organization, will get paid less. So when you rely on payer data, one of the biggest challenges is that you don't have any way to validate, is the payer actually paying you appropriately for the work you're doing? So the third area that we can get data is the billing system. The billing system, although the data can be limited in terms of we don't have all of the data, unlike the EHR, the billing system, we do have good data though, because we understand we've got validated diagnosis codes, the coding's usually audited, and it's fairly easy to work with these data set because of the standardization with claims data that's coming in. But ultimately here at PDS, we're usually looking and working to try to bring all the different data sources together to make sure we have, as complete of a picture as we can. So let's take that last chart that we looked at, Kelly, and let's dig just a little deeper into what can we do now that we have not only the patients that have HCCs, which we're seeing here. These are the actual physicians, but you'll notice here right on the right side of the screen, we've now, the patient counts, we've assigned the annual revenue that's impacted by those patients to the organization. So we can start to now prioritize not only patients that are high risk, which you'll see down the bottom here. I can simply point and click and filter through patients that are high risk or moderate risk. We can start to see in which areas that they're working, what are the HCCs. We could continue to filter through the locations, the practices, and really make sure that where we're prioritizing and trying to get the patients that really need the most attention in first, this is where we would want to drill in and then pull out those patient lists as you'll see in just a minute. So this is just one representation of that. To go a little further, and we talk about this quite a bit here at PDS, we've taken the same physicians, we've taken their risk scores by year, their average risk score, and we're then benchmarking them in a dashboard to try to understand where we have physicians that their risk scores have gone down. And so you'll notice here, this is the averages for the organization. We can see the number of patients that are in prior year, current year. And then we can start to look right down the screen here at the comparison, and we can start to see where physicians have negative scores, a little bit like what Kelly was showing in those gaps. We can also see where the patient counts of patients that had HCCs have gone down. Now, again, this may be, maybe we lost some patients or other things, but the key here is then we can start to project if we can better risk assess our patients, focusing on their risk scores, ensuring that where we scored them in prior years were at least equivalent coding and measuring all their diagnoses. We can start to forecast where there's opportunity financially, as well as, identify the patients with the highest risk or the patients that just haven't been seen because we haven't been able to get them in due to the pandemic. So this is just another example of looking at the same information a different way. Now, the question here is you certainly wouldn't want to show this to a physician. This is more of a financial view or a CFO view to the organization. Kelly, what would you recommend, and how do we help physicians sort through some of that?
Sure. So this particular report focuses on an individual provider's patient population. So how many patients is this provider responsible for? And then out of those patients, how many have been scored with an HCC? So how many of those are higher risk than out of that entire patient population? It also gives the provider some information about the average scores of these patients, which of course their age does go into that. So if they're seeing older patients, those scores would be a little higher too, even if there are no chronic conditions assigned. And it gives them the chance to look at this year over year. And up at the top of this report, it quickly shows kind of what needs to be done. So how many patients are we expecting to kind of see that we haven't from a chronic condition standpoint yet?
I think this very simply in the top of the screen nets out. You've got 27 patients that need to be seen before year end to ensure that we've appropriately treated and coded our chronic condition patients. And this, again, very useful in being able to provide, whether it's weekly or monthly dashboards back. But I know this dashboard, Kelly, is not your favorite because it's a little more just numeric. We've got just simple indicators. I know you like something a little more graphical. Do you want to share our latest infographic here and what we're showing here?
Yes, I like these new dashboards. It gives the same information, a lot of the same information, especially down the left-hand side. We've got that patient population information and those number of higher risk patients. And still we have that ability to report year over year data. And now we're able to blend in some compliance data to this information. And then we also can report some wellness visit compliance and utilization. And I know, Russell, you wanted to speak specifically to some Medicare Wellness visit information today.
You just can't speak about HCCs and not understand the annual wellness visit. And what's interesting is it still tends to be one of the most underutilized services by organizations. And in my mind, we're really leaving a lot of money on the table if your organization isn't sort of aggressively pursuing these. But this next slide here that you're seeing on the screen, I pulled right out of a CMS pamphlet, and it says Medicare coverage of physical exams, right? So most organizations, I'm sure you're aware, the IPPE, the preventive physical exam, the initial exam is covered by Medicare. But Medicare, they don't cover routine physicals. They're not included, and very clearly, but where there's so much opportunity and this service is just so underutilized is the annual wellness visits. And the very definition, visit to develop or update a personalized prevention plan and perform a health risk assessment. So whether the patient has chronic conditions or they don't, we have this opportunity. But in particular, to perform this health assessment, the reimbursement tends to be higher. We can bundle it with other services while the patient is visiting, and it's covered once every 12 months. There's no cost to the patient. So in reading, I just recently found yet another article. I was hoping to see there's certainly a trend that more and more organizations are moving. About a year ago or so, we were looking at statistics around 10 to 15%. I think they've moved from about 15 to maybe 20%. So there's a very slow trend. And speaking with a lot of our practices, what we found is many organizations are doing less than 5%. And then some of the better practicing organizations are really focused and doing, 60, 70, 80%. And there's this just real big gap in the middle here. But the key to doing this is understanding who's eligible, who's having wellness visits, which physicians are performing them, and where are those opportunities. So we go right back to the power of the analytics to be able to understand that. So let's take a look at a quick visualization where we're now looking at the patients and their conditions. And Kelly, how do we use this and what's going on the screen here?
Yes, so with the Medicare Wellness visits, those are billed based on the CPT code. So we can pretty easily tell when the last time one of those Medicare Wellness visits was performed based on those CPT or procedure codes. So we'll look at this by patient, HCC. So if we're looking for a specific condition, or we can look at our population as a whole to say, hey, I want to see all of my Medicare patients that are past due for a wellness visit. And once I limit to that data set, I can say, okay, now if we don't have Medicare Wellness visit, do I have an appointment scheduled for this patient? So if we have an appointment coming up, then we're probably okay. If not, we want to take action and get that patient scheduled for back in the practice. And we can also start to look at their risk level. So if we want to focus on those higher risk patients versus the lower risk patients first to make sure we get them in and seen, we can easily point and click and limit that population and start addressing those patients. I also want to point out here, so this is specific to a Medicare population. There's no reason this same type of logic or strategy can't apply to non-Medicare practices. So if you have a pediatric practice, for example, and you want to focus on getting your diabetic patients in, you can, whether they're due for an physical exam, annual physical exam, or a periodic wellness visit because they need to be seen more frequently, you can kind of apply that same type of structure here to identify those higher risk patients, even for non-Medicare.
I think this is just such a good example of using analytics to, one, identify the gaps, and then two, try to prioritize, right? So it's not just who needs to come back, but let's focus on who needs to come back with the highest HCCs, and we'll try to focus on that population first, trying to keep them out of the hospital and keep them well. Once again, to make information actionable, we can look at, and we talk about this in many of our webinars, right? So there's within an organization, as the organization uses analytics, they mature across the bottom here, this x-axis, and then what we call analytical intensity. And so organizations tend to summarize data and look at trends, right? We start to bring in benchmarks. But what you're seeing on that last report is we're correlating scheduling data with their risk acuity data. So from an analytical side, we've got to correlate those two tables. And then what we can do, again, similar to the other report I showed, is we can project what's the impact on the organization, which physicians would most benefit, which patients, which care teams, how can we better utilize providing better care? And, oh, by the way, as we provide better care, we're going to get paid more. So what you're looking at here, again, is another performance opportunity dashboard, and this activity is really showing how many patients we have within this, say, practice or department, how many patients are over age 65 that would be eligible, how many wellness visits we did last year, potentially, right? So we could use that as a benchmark. So you can see we have some physicians at 17 and 15%. We have a couple that are up in their 30s. And then we have one here that's at 3%. We have another one down here at 10%. This is what we did. This is just facts, what we did. The next section of our dashboard here is, well, what if we increased to 65% of the eligible patients had wellness visits? Or what if we could get each individual physician maybe to have a goal of increasing 15%? How many more patients would we see for wellness visits? Or what if the physicians that are below our 17.8% average, if we could just move them up to the average within the department, we would see 1,100 more patients. We can then extrapolate out and model and project based on the average reimbursement in our market for those patients, how much more revenue we're going to see, how much more revenue is going to be attributed to each physician. And then we can obviously highlight where the largest opportunities are. So if we're thinking about trying to improve performance, or even if we want to focus on compensation, these are some areas, again, that can point an executive to helping drive how and where do we see more opportunity, and even potentially help support the care teams by having this information and knowing where the focus is. This, again, is much more analytical. Kelly, do you want to walk us through the more visual version of this dashboard?
Yes, and sorry, but once again, I like this one a little bit better. We kind of took the same approach here, where what happens if providers can increase wellness visit compliance by 15%, or what if they can make it up to the department average. So down on the bottom left, you can clearly see the providers that are on the outlier, and below that green line indicates that those are below the department average. So I'm quickly able to limit it down to those providers and see what their activity looks like up there at the top.
Very easy to use, clearly see the gaps, and being able to quantify that right in the screen certainly, makes it impactful. And of course, you could run this, provide this out to leadership, or even if you have transparency in your organization and there's a focus, even allowing the physicians to understand how they're performing against their peers, potentially. To me, patient risk acuity, is really about identifying gaps. We're using these HCCs to look for either reporting gaps or clinical care gaps. We may be providing the right care, but if we're not coding and providing that information to the insurance companies, we don't know. And then as we're identifying those gaps, of course, we can focus on closing the gaps, and we need good reporting to know that we're moving in the right direction. We've changed our behavior to measure and monitor, so we can then provide feedback as to where the new gaps are, right? So it's really being able to assign out the challenges we're seeing with our data, or we're seeing in the organization, and then communicating to sort of close the loop on the circle here. Given what's gone on with COVID, what's gone on with patients, I know I had a few visits. Kelly, you and I have talked about not being able to go to the dentist, same thing. I didn't even bother. I had a dental appointment showed up on my schedule. I said, I'm just not going. I think they left me a message saying, you're not supposed to come in at that point. But it certainly impacted patient access, and a lot of patients are sort of out of sync with their ongoing care, especially for chronic conditions. And so really, I think the key to our whole industry is getting back and focusing on those patients that really need those services to stay healthy and to stay out of the hospital.
And hopefully practices are able to leverage those HCC and risk scores to help manage patients that are at greater risk, and hopefully that'll help ensure a better quality of care. And by providing that better quality of care, those payer models that reimburse or incentivize based on that quality should help the practice bottom line as we move forward.
One of the consultants who was a former customer that used to work with us used to like to say, make data meaningful, make it visual, and make it actionable. And so I just want to give a quick shout out to her as well. But I think as we talk through this, and you see what we're really trying to do here is take information and turn it into both visual and actionable data that we can act on. I do want to say, if you're a PDS customer who joined us today, thank you for being a customer. If you're not a PDS customer, if you'd like to learn more about PDS, please feel free to call us, visit our website, or our YouTube channel has quite a bit of information and examples of the different areas that we're helping organizations in. Kelly, did you have anything else you want to add today? Thank you for doing this webinar with me.
No problem. I'd just like to thank everybody for taking the time today, and hopefully we'll be able to get in person with people soon.
Yeah, hopefully we'll get
ready
to each other in a better
people.
fashion than just web meeting, right? Yeah.
Yes.
Just one more thing. Please do thank your physicians, your care teams, all the clinicians that are taking care of people and really are the heroes through this pandemic. We certainly admire and appreciate everything they do. So thank you for that as well. Have a wonderful day. Thank you for joining us, and hopefully we'll hear from you or see you at a future webcast coming up. Thank you.
Thanks,
again.
everybody.
Have a great day. Bye-bye.